There have been many, many challenges surrounding the COVID pandemic, including how will we provide care, gigantic budgetary challenges, trying to figure out what happens with the incoming class, trying to figure out how to re-engage our medical students. You know, hardly a day goes by without a new and different challenge.
Instantaneously, we crashed down the clinical services here. And over a period of about 48 hours, we went from seeing 14,000 patients a day to 1,000 patients on the outpatient side. And over a week, our procedures, surgeries, and endoscopies decreased by 95%.
Our science, we closed down our labs, right? But the idea wasn't that we closed them down because we don't care about science anymore. We closed them down because it was safe. It was a safe thing to do. But we still have the same exact missions.
And all the while, I felt like these decisions that we were making together as a group were done as kind of humanistically and compassionately as they could, recognizing there was this sense of urgency.
When you deal with an outpatient person, you're managing their blood pressure, but that's over months. When you deal with a patient in a hospital, it might be something over a couple of days. When you're in the ICU, it's minute to minute or hour to hour on how you manage things. And I think normally we went through our routine things, and sometimes little crises come up, but they're usually dealt with. But I would say on average, we would deal with things, maybe on a weekly or monthly basis, new things. But when COVID came, it's like going into the ICU. There was things happening so fast, and you had to make decisions based on information you had at the time, many of it not complete, to move forward and adjust things. And so I likened it to going from the outpatient to the ICU in a very, very fast manner, sometimes not with all the information that you really need to make sometimes the best decision. And so COVID really brought that upon us.
So we had a rapid cycle kind of assessment as things changed. One of those was, in the beginning we thought things would be really bad, right? We would run out of beds really fast. And then, that held true for 3 weeks or so. And then as things started to change, we acknowledged, hey, things are changing in our environment.
And so I think having a really impactful mission to work toward with a team where there was kind of mutual respect coming in made a lot of difference.
So my why is to get us through this crisis, to support my team through the crisis so that we come out on the other side and can be stronger than we were when we started.
So what I think is the most important thing first is that your team believes that you have their best interests at heart. So what I think that means as a leader is that my first job is to think of the safety of the people working for me and to make sure that they understand that that's my first concern.
If you don't respect the people around you and treat yourself the way you want to treat someone else, then it's going to be a very short journey.
So my first kind of major decision as a leader was to refuse to open the RICU. I remember this on day one. We did a walkthrough, and the command center, who are all people who are much more powerful than I am, including my boss, who I respect very much, were all saying, okay, it's time to open the RICU. But they were in another room coordinating all of this through the command center. And I was actually in the RICU with my team of doctors and the nurses, and there were just a lot of people that were concerned about things. They were all small issues, like I don't know where my suction is, or I don't know where the trash can is in this room. Things like that we all kind of overlook, but you could just feel that there was this palpable anxiety. And I said, no, we're not opening the RICU. And I got a lot of pressure and pushback, and I was like, we don't know if it's safe here. Let's make sure it's safe first. And my boss, I give him a ton of credit. He said, okay, you have ground control. You tell me when you're ready. You tell me when it's safe. And so what we decided was we'd take one patient first, even though we had, a dozen nurses and half a dozen doctors already in the RICU ready to take patients. we decided as a group we were going to take one patient first and then work out any issues that occurred during that one transfer. And then once that occurred safely, to kind of open the floodgates and let everyone else come. And that really created time and safety to make sure that not only were the patients safe coming in, but my staff and all the nurses and everything like that were safe coming in. So, you know, I think it's really hard to make those decisions when, you know, people are telling you to move, but your first and foremost concern needs to be safety.
Was bringing in patients from outside facilities, outside hospitals, the right thing to do? Yes, it's the only thing we could do. Were we fully prepared to care for them? No, but there's incredibly talented people here, and we figured it out in the fly. Will there be ramifications of deciding to do that? You bet. If you look at the financial implications of what we did, it is huge. And now we'll be dealing with that for the next several years.
Presenting, if you're sort of looking at a decision through the lens of, is it the best thing for patient care? It's usually hard to be faulted for that decision if that's the lens through which you look at it. And I always seem to, I mean, that's one of those foundational things in healthcare. If you make a decision that advantages somebody, but it's not the best thing for patient care, that's not exactly a limb you want to be, out there on. Whereas if you're going to do something that's controversial, some people are not going to like it. If you can say, I'm sorry, but if this were my family member, my parent, and in fact, I even remember a time with Vineet Chopra, who's our chief of hospital medicine, and I were on a call with all of our faculty. And that's a comment he actually said that I'm like, that's exactly right. He's like, listen, we're all taking care of COVID patients. If I get sick and I'm critically ill in the hospital, it's like, I want you guys. And I think that's the lens through which we're making this decision.
Sometimes that's not a happy decision, right? I mean, one of the things they say, people don't like this quote very much, but sometimes I think the best compromise is when everyone's equally unhappy, because, that's really when you're making some of these compromising decisions, that's really what you're managing is people's disappointment or what they're not getting. You can never give them enough. They'll always want more. So if you really think about how you're kind of managing the downside of all those things, I think that's really kind of one way to kind of get to more equitable or agreed upon compromise.
You're not gonna be able to make everyone happy.
Which we all know, but to hear it, I think, goes a long way. And just to sort of reflect that you can't make everyone happy, and some of these decisions will make people unhappy.
When I was a division chief, let's say I had 50 people, and this is hypothetical, but let's say some wealthy lady gave us $50 million. And so I made the executive decision. I said at the faculty meeting that I made the decision that every one of you will get $1 million in your discretionary fund from this donation. Guess what would happen? 46 of them would say, fantastic. 4 would complain about it. So the bottom line is, even if you give a gift to someone, not everyone's going to be happy about it. So I'm happy if 80 or 90% of the people are happy with some of the decisions.
And so then how do you then get to this sort of sense of shared agreement and purpose and mutual respect? And so saying, listen, I'm sorry, I don't really know, but I'd love for you to give me 2 minutes to tell me why you want to do this.
One of my great mentors says, never assume malice when ignorance will suffice. And what he's trying to say is that don't think that people are trying to do bad. They're usually, if something is happening that is incorrect, it's less that they're actively trying to be evil and more that they don't know enough to know that they're safe, or that they have a valid reason that you don't know about, and it's actually ignorance on your part that makes you interpret their actions as malevolent. So instead of getting angry about something, seek to understand first.
But I think that knowing yourself and knowing where and being able to talk through those things with people, especially if you're in constructive, the conflict can be constructive if you both know that and you can talk through it. because then you find the middle ground rather than just reacting it as like, I'm right and they're wrong, right? You get your ego out of the conflict. And so, by the way, that this right here is a leadership mental model, right? The number one source of conflict is when people mix up their person and their sense of ego with the problem. And one of them is just swallowing your pride, like actively being like, my ego's caught up in this. I'm going to do something now to swallow my pride, right? Which will automatically, if you just say, you know what, I think that right now we're in conflict because I just don't want to be wrong. So can we just admit it and then say, let's boil this down to the principles.
When you confront something, and this was pre-crisis, you should make a decision. I'm like, really? What if you don't have all the information? He goes, it's the 80-20 rule. 80% of the time you'll be right because your gut and your experience will say this is the right thing, and 20% you're going to be wrong. I said, wrong? 20% of the time? And, because we always focus on the negative. But he said, listen, the key thing is keep listening, because if you're willing to admit you're wrong and fix that 20%, you'll be a much better leader. So, it's still better to make a decision than have indecision. Because indecision, people that work under you will go in different directions and not get things done. So you might turn them in the wrong direction, but if new information tells you, nope, that's wrong, we got to go this way, you got to be willing to admit that and correct that.
Another thing I think you need is what I call process partners, people who you trust and you can talk to, that you can just run by an email or a conversation. Because in times of stress, sometimes you're not thinking as clearly or you're emotionally wrapped up in the situation, and you need someone separate who you trust, who's not emotionally wrapped up, who can give you objective views.
Like I do that a lot with my peers, really discussing and usually that because if you want to strategize to influence a process, sometimes you need a contingent. So I think that's still productive. That's not complaining. Is like, okay, listen, I think we could have done this better. How can we influence this process as a group, right, with common interests? That's coalition building. I mean, sometimes that's involved when you're kind of diagnosing decision making.
But I wish we could do more. It's not clinical reasoning, but it's leadership reasoning. And instead of just people saying, well, these are the decisions they've made.
But to look back objectively and fairly, but with some level of critique and criticism on either how you behaved in a circumstance and that either promoted success in that or did not, or and to think about kind of what you could have done differently or how you could have managed that differently. And then to kind of distill that into either practices or principles that you would use going forward to be more effective.
Because I do think there's a lot to learn, things that we did well, things we could do better, preparing for something like this to happen again, which is, is possible. And just in general, making our health system more flexible, more agile.